May I introduce Professor Phillips Emmanuel. He will speak to us about current bronchoscopic guidelines in the COVID-19 pandemic and implementation strategy in it.
Thank you so much for the invitation. It's an honor to be among you, and thanks to the organizing committee for having me to speak about bronchoscopy in the COVID-19 era. It's indeed a very fascinating topic. I'm an interventional pulmonologist based in Athens. I have several hats. I'm the ex-coordinator of ex-chair of the working group of 5P for the Hellenic Thoracic Society, and I represent Greece in the EABIP and I'm chair in WABI. Indeed, 2020 was a year that changed the face of the earth. Since the 3rd of January, that the Wuhan cluster of patients, 44 patients were reported to WHO. A lot of things have changed in our clinical practice. Since my last talk on COVID-19, I always check this Johns Hopkins screen. 20 million cases have been added, 2 million deaths also. A huge local cluster was created in India with a lot of fatalities and a lot of cases. Now India is second only to the US, but also there are a lot of fatalities in Brazil. So we have a pandemic that is actually running. So we have to think about our practice and how we can optimize it in order to not risk our patients and ourselves. So what are the issues about COVID-19 and bronchoscopy? It seems that it's not enough to base our practice on symptoms because there are a lot of asymptomatic patients. And when you have an asymptomatic patient in the endoscopy room, you risk making a super infection, a super spreader situation and spread to the nurses, to the staff, and to other patients because bronchoscopy is a respiratory droplet spreading procedure. Also, our patients that come to the bronchoscopy suite are a special group. They are immunosuppressed because they have malignancies, they have infections or other autoimmune disorders. Therefore, they are more prone to COVID-19 infections. So there are several questions that were asked early in the pandemic. Should we check all patients with swabs prior to bronchoscopy? If we have a patient that is suspicious for COVID-19, when should we do a bronchoscopy? And what are the indications? What indications are considered an emergency in the case of COVID-19 pandemic? And also, are there any international guidelines that we should read and follow? The first guidelines that appeared are, of course, the Chinese guidelines due to the pandemic that started in China. The problem with this is the original publication. The problem with this is that they were in Chinese. So since we were involved early on, I came to translate them, and I have to say that they were quite proficient. They are mentioning that bronchoscopy is not means to diagnose COVID-19. We have to adhere to strict regional safety protocols. We should examine our indication and postpone bronchoscopy if necessary. We must clinically examine all our patients and do thermometry, separate suspicious versus non-suspicious patient, and use excellent gear for our personnel for protecting them. The Chinese guidelines mention that negative pressure rooms are preferred when available, and they recommend laryngeal masks or intubation for confirmed or suspicious patients that undergo bronchoscopy. And also they could recommend UV light for decontamination of the bronchoscopy suite. As the pandemic spread to the rest of the world, we had these first opinion-based, expert opinion-based guidelines from the American Association for Bronchology, Interventional Pulmonology. They were only opinions of experts with main purpose to ensure the safety of the patients, the healthcare team, and the community at large. And these were more specifically addressed in this CHEST guidelines. This is a CHEST AABIP guideline and expert panel report. We had some questions asked regarding the population that we are we are interested in the intervention that we have to do in order to protect the population and ourselves, and what is the outcome that we can get from this intervention. So the first recommendation is that when patients with suspected or confirmed COVID-19 infection are undergoing bronchoscopy, we should gear up really closely. We must wear an N95 respirator or use these powered air purifying respirators, which are not very common. Also, we have to wear a face shield, gown, and gloves. When we finish the bronchoscopy, we should discard our N95 respirators, our more intricate masks that we use. Prior to doing bronchoscopy, chest ABIP expert panel reports recommends doing an esophageal swab. If we have a patient that is intubated and has severe disease, if we need to do bronchoscopy, this must be done in order to change the clinical management, collect samples from the lower respiratory tract, and in this case, then we can perform a bronchoscopy with BAL. How efficient is bronchoscopy to diagnose SARS-CoV-2? In this panel of 28 patients, after 3 negative swabs were done in 3 different days, and also they did a negative serology test, all consecutive bronchoscopies were actually negative, even though the patients have highly suggestive CT scans. So in this study, it was not very clear whether we should do bronchoscopy after 3 consecutive negative swabs. And nevertheless, there were other reports. This is a radiology paper that says that they had 36 patients with very suspicious radiologic findings for COVID-19 pneumonia. They used a very elaborate system of testing. They did 3 consecutive swabbings. And with the initial test, they missed 6 patients. These 6 patients, 3 became positive in the second PCR test, serial testing, after 2 days and 3 days respectively, and the other 3 became after 5, 6, and 8 days respectively. So the authors said that CT scan is more sensitive to detect COVID-19 than even the original first PCR that we do. The sensitivity was only 83%. So this is a study that came from Italy from the first pandemic that showed that actually if we do a bronchoscopy after a series of swabs, of negative swabs, we can get a diagnosis of COVID-19 in about 50% of patients. So bronchoscopy is useful in very suspicious patients with radiologic image that looks like COVID-19, and all our swabbing consecutively are negative. When we have a patient for another indication, the first thing we do is we do a PCR prior to bronchoscopy. It is ungraded consensus, but for sure it is highly recommended to have a negative PCR before you do elective bronchoscopy. Even if you have a negative swab, the procedure should take place for the doctor and the nursing staff that will do the bronchoscopy in the same way that we would do a swab positive bronchoscopy. It means we have to wear the face shield, the gowns, the gloves, and the N95 respirators, nevertheless, even if we have a negative swab. And this is a picture from how we are preparing for a rigid bronchoscopy from in our suite. We are geared up, we wear all our equipment, even though we have a swab negative patient. Also, this is courtesy from an Indian colleague, very expert bronchoscopist, who is doing his bronchoscopies now in the pandemic in this PAPR suit. There are several techniques that have evolved, and these are publications from around the world that we use some techniques in order not to spread the droplets. This is a more elaborate plexiglass construction that is for intubating or doing a bronchoscopy in the patient. In the middle, also another plexiglass construction. Even when these are not necessary and we are doing mild sedation, we have to avoid the patient to cough, and we have to cover him properly not to get as many droplets in the atmosphere. This is a publication from the NHS from the United Kingdom. They found a way to prepare a portable negative pressure environment in order to intubate a patient in an urgent way or do an urgent bronchoscopy with just material, with a stretcher and some material they have in the ward. It's called the Splash by B, the design. You can see it in the link if you want to replicate it. And of course, it is highly important to train properly in how to put on the clothes and take them off. I was very much surprised when the responsible nurse trained me for the first time, and I omitted a lot of details which are quite important when we are dealing with COVID-19 patients in order to protect yourselves when donning and doffing, means taking off. It is also important to consider that each hospital is different. So these are the Cleveland Clinic local guidelines. So we don't need to support only the international guidelines, but we ourselves in every hospital, in every institution, we have to discuss with the nurses, the staff, the administration, that we have to have personalized local guidelines which should be adhered and followed up in every circumstance. We must remember that the guidelines always say that even though we have a pandemic, we have a lung cancer epidemic as well. So we must give our resources for lung cancer. We must not postpone our bronchoscopies. We have to find a way in order to be very precise in the diagnosis and staging of lung cancer, do our bronchoscopies, and these patients cannot be delayed at all. So we have to find the appropriate strategy. Is it easy? No, it's not easy. This is also a study from the NHS that said that in the first months of the pandemic, it was impossible for them, due to the allocation of their resources somewhere else, it was impossible to keep up with their bronchoscopy. So there were significant delays in flexible bronchoscopy, but they tried in the period that followed to correct this. And this is how we should proceed. There are urgent and super urgent situations when we have tracheal or bronchial obstruction from tumor or from benign etiologies. These are considered, we have a hemoptysis, these are considered very urgent situations. We have to gear up and do a needed bronchoscopy. If we have some time to plan, still lung cancer screening and lung cancer diagnosis and staging is considered an emergency. So we have to organize this, but of course we can do a negative swab to the patient prior to bronchoscopy. It's not that urgent. If you want to do other procedures which are elective, such as bronchoscopic lung volume reduction, then we can plan the patient for later on if we have a lot of cases and we don't have the resources. In the beginning of the pandemic, there were quite some controversial publications, even from really expert people, that when possible we have to avoid bronchoscopy in order to not create a super spreader situation. And for stage 1 and stage 2 cancer, they went to the point not to recommend a procedure, bronchoscopic procedure in the beginning, but to go either to surgery or FNA biopsies in the CT scanner. This is not considered anymore an emergency. We can plan our procedures, do a bronchoscopy in a quiet manner, and not send the patients directly for surgery. If we have a patient that is positive, how long should we wait? It is not known, but for sure we have to wait for a month or have 2 consecutive swabs that are negative in order to do a bronchoscopy, an elective bronchoscopy, such as a diagnosis for lung cancer. We shouldn't wait for a month. We at least have to have 2 negative swabs. I had the honor as coordinator of the IP group to participate in the Greek instructions. I strongly recommend all Egyptian societies to discuss and have appropriate local and national guidelines for bronchoscopy in COVID-19 for all aspects. It is a very satisfying procedure, and the doctors find guidance in such national guidelines. So when we do bronchoscopy, what do we prefer? There are a lot of publications that recommend moderate to deep intravenous mask, which avoids a lot of respiratory droplets to be in the atmosphere. It is a very satisfying procedure, but you have to have an anesthesiologist to do this. We have an announcement at the Congress some time ago using this particular laryngeal mask, which molds on the larynx, doesn't cause any droplets to go away, and it is a very easy procedure if you have an anesthetist. Otherwise, you need to have moderate sedation. A lot of publications on the use of these single-use bronchoscopes. This is one of the first models, AMBU, which can be used several times in the same patient, but of course not switch between patients. It's very easy to use because if you don't have an organized bronchoscopy suite in your department, in your hospital, you can have this tablet and the one-use bronchoscope, and you can do all your simple bronchoscopies, even take some biopsies if necessary, do some washing, take out mucus plugs without need to decontaminate the whole tower. Just wash the tablet with which is waterproof. These one-use bronchoscopes have become, in the last year, very elaborate and with a very good imaging. You can see a later model. They presented this some days ago. It has several sizes to use in particular indications, and it's very, very mobile and very agile. You can see here a study from the ICU. There were two bronchoscopists doing 100 bronchoscopies in 93 COVID patients. During these procedures, unfortunate, the patients that underwent bronchoscopy were in serious condition. They had 8% of FiO2 with a median PEEP of 10, so bad cases. The most of the procedures were done because there was a change in the radiological or clinical picture. There was a deterioration. They wanted to get samples from the periphery for bronchial cultures. And also there were cases of atelectasis from mucus plugs. What we see when we do a bronchoscopy in the COVID-19 patient, we see either normal or hyperemic bronchial mucosa. We see diffuse white and jelly secretions, which are difficult to suction. And in some cases, we have bleeding. We have mucus with blood, which are very difficult to take out, and you need cryotherapy, to be trained in cryotherapy to take out these molds, these bronchial molds. This is second study later on, which no bronchoscopists got infected. They took microbiological samples, they removed bronchial plugs, and of course, in both studies, they used only disposable. Experience is growing. More of us are doing bronchoscopies in COVID-19 patients in the ICU, and more publications will arise. So we have several challenges that are not actually very much well addressed in the guidelines. We have a rise in the post-intubation tracheal stenosis incidence. We have incidents of tracheoesophageal fistulas due to trauma during intubation. We have more and more tracheal stents that we have now to manage and review and take the mucus plugs off. And also we have some cases where we have to remove the blood clots, as I mentioned previously, with a cryotherapy. So this is a study saying that for COVID-19 patients, it is quite usual to have median duration of ventilation more than 17 days, and some of them are also re-intubated. So the incidence of post-intubation tracheal stenosis rises. This is due to overcuffed intubation. We have patients that are in prone ventilation. This can contribute, and also it has been seen that there is a connection between PITS and obesity, and COVID is also connected to obesity. So these three form a triangle. Here you can see one of our cases. This is a post-COVID PITS. We found a trachea which was 5 millimeters. We had to dilate with a rigid scope, cauterize the granulomas, and finally we put an hourglass stent to keep the lumen patent. We have to have our surgeons also in place because we have many cases of some cases of tracheoesophageal stenosis and fistulas, like this case report from the UK, that we cannot manage endoscopically and had to have surgery, difficult surgery for the patient, as you can see in the picture below. Muscle flaps used to close the gaps. We have to suture the esophagus, and there are many complications afterwards. So always remember, when we search for fistulas, we have to first to see the endoscopic way. We use methylene blue diluted into water through the lumen if there is any point where there is a connection with the trachea. As you can see in the pictures below, below the silicon stent, we have a connection where the methylene blue comes into the trachea from the esophagus. So this is a very useful method to use in the ICU. And don't always forget to deflate the cuff for doing this, because the cuff could cover the fistula. Always have in mind that for benign conditions, benign stenosis, we use silicone stents. We don't use metal stents because after some time we may be able to remove this and have a normal trachea. And if we use a metal stent which is not covered, we can do more damage than good. And with this, I would like to conclude my talk. I would like to invite you tomorrow morning at 11:30 Cairo time. We have in this channel, under the auspices of the European Association of Bronchology Interventional Pulmonology, we have a live case of lung volume reduction, bronchoscopic lung volume reduction, which is very interesting, will be commented by international experts. So I invite you to join us at the site that you see below. And also I would like to invite you to the 6th European Congress for Bronchology Interventional Pulmonology that will take place in Athens in October. It will also be in a hybrid form, so you can watch from the internet if you can join us in Athens. Our team with Professor Stratakos will organize this event, and it will be a very interesting opportunity to meet and exchange opinions on all matters of IP. Thank you so much.
Thank you very much, Professor Philip, for your valuable presentation. And the floor is open for any questions for Professor Philip. Okay, so we don't have any questions right now. Thank you very much for your kind presentation.
Bye.
Okay, thank you very much.
Bye-bye.
Bye-bye.